Welcome to this learning module on cow's milk allergy in infancy. This module is designed for healthcare professionals working in pharmacy and will focus on recognising, differentiating and appropriately managing cow's milk allergy in infants. By the end of this module, you should feel confident in identifying the symptoms of cow's milk protein allergy, including the key differences between IgE-mediated and non-IgE-mediated allergy, recognising how cow's milk allergy differs from lactose intolerance, understanding the recommended feeding options in Australia, knowing when referral back to a GP or a paediatrician is appropriate, avoiding overdiagnosis of cow's milk allergy by applying evidence-based diagnostic principles, recognising that many symptoms attributed to cow's milk allergy, such as colic, reflux, and loose stools, are common in infancy and often non-allergenic. This module will help you identify when cow's milk allergy is likely, when it is unlikely, and how to minimise unnecessary restriction or formula changes. An allergy is an abnormal immune response to a normally harmless substance, most commonly a protein. In food allergy, the immune system recognises food proteins as a threat and mounts a response that leads to clinical symptoms. These responses can be immediate, involving IgE antibodies, or it can be delayed, involving non-IgE immune pathways. Understanding these mechanisms is essential as they directly influence how cow's milk allergy presents and how it should be managed. It is important to highlight that food allergies are triggered by protein, as later in the module we look at the difference between cow's milk protein allergy and lactose intolerance. Cow's milk allergy can be broadly divided into IgE and non-IgE mediated disease. IgE-mediated reactions occur quickly, usually within minutes to 2 hours after ingestion, and can affect multiple organ systems, including the skin, gastrointestinal tract, respiratory system, or even result in anaphylaxis. IgE-mediated cow's milk allergy has validated diagnostic tools, including skin prick testing, serum-specific IgE testing, oral food challenges, which are gold standard. These should be interpreted alongside clinical history. Whereas non-IgE mediated allergy presents more slowly, often hours to days after ingestion of the allergen. Symptoms are typically gastrointestinal and include reflux-like symptoms, allergic colitis, or eosinophilic esophagitis. Non-IgE mediated cow's milk allergy presents diagnostic challenges with wide-ranging symptoms which can overlap with many other conditions and the lack of validated diagnostic tests. Diagnosis of non-IgE allergy relies on clinical history, elimination diets, and reintroduction to confirm if appropriate. Cow's milk allergy can present with a wide range of symptoms, many of which are non-specific. Careful clinical evaluation is essential to avoid both misdiagnosis and overdiagnosis. Symptoms may involve the gastrointestinal tract, skin, respiratory system, or behaviour, and many infants experience symptoms across more than one system. As we have seen in the previous slide, non-IgE mediated cow's milk allergy can present with symptoms such as vomiting, diarrhoea, constipation, eczema, irritability, feeding difficulties, or blood in the stool. These symptoms overlap with common paediatric conditions such as viral gastroenteritis, lactose intolerance, reflux, colic, and functional gastrointestinal disorders. Because symptoms are broad and non-specific, and because there are no validated diagnostic tests, overdiagnosis of non-IgE cow's milk allergy is common. As pharmacists, recognising patterns and red flags can help guide timely referral and appropriate management. Food allergy rates in Australia and New Zealand are amongst the highest in the world. Around 10% of infants have a food allergy, and cow's milk allergy is one of the most common. Approximately 2% of infants are allergic to cow's milk. While many children outgrow cow's milk allergy by early childhood, it can persist until 3 to 5 years of age in some cases. It is important that pharmacists are familiar with the typical presentations of cow's milk allergy and the referral criteria to help ensure infants are managed safely and efficiently, and that families receive appropriate specialist input when required. Pharmacists are important in preventing misdiagnosis and inappropriate formula prescribing. You can help by checking whether an elimination rechallenge process has been followed before dispensing the specialist formula, clarifying whether symptoms fit IgE or non-IgE cow's milk allergy, especially when parents request formula changes without clinical review, encouraging referral back to the primary care or back to paediatricians when cow's milk allergy is suspected, but diagnostic steps haven't been followed, and advising against switching formulas repeatedly, as this often increases confusion and delays proper diagnosis. Misdiagnosis of cow's milk allergy carries significant risks. These include nutritional deficiencies, poor growth, unnecessary dietary restriction, reduced quality of life for families, and increased healthcare costs. A recent report by Deloitte Access Economics for the Australian Society of Clinical Immunology and Allergy, otherwise known as ASCIA, and the National Allergy Council provides key insights into the economic and social impacts of allergic disease in Australia. You can read this report on the ASCIA site. Lactose intolerance and cow's milk allergy are frequently confused, but they are very different conditions. It's important to distinguish lactose intolerance from cow's milk protein allergy, as the two conditions are fundamentally different and require very different management approaches. Lactose is the main carbohydrate in human and mammalian milk. Lactose intolerance is not an allergy. It results from insufficient lactase enzyme activity, leading to difficulty digesting lactose, the natural sugar found in milk. Because healthy term infants are born with adequate lactase levels, true primary lactose intolerance is actually quite rare in young infants. Secondary lactose intolerance may occur, but usually follows gut injury, such as after a viral gastroenteritis. In contrast, cow's milk protein allergy is an immune-mediated reaction to the milk protein. Because the gastrointestinal symptoms of both conditions can overlap, such as abdominal discomfort, bloating, diarrhea, confusion between lactose intolerance and cow's milk allergy is common. Confusion between these two conditions often leads to inappropriate dietary management, which may compromise nutritional intake or delay the proper diagnosis and treatment. Dietary avoidance of cow's milk protein is the only effective management strategy for infants with cow's milk allergy. Breast milk remains a gold standard for infant nutrition, including for infants with cow's milk allergy. Breastfeeding mothers may require support to safely remove cow's milk protein from their own diet, while avoiding unnecessary dietary restriction. Dietitian support is important when removing foods from a mother or the infant's diet, as well as timely and structured reintroduction. When breastfeeding is not possible, safe and appropriate formula options should be selected based on the infant's age and clinical presentation. The ASCIA Management Guide for formula-fed infants will be discussed in more detail later in this presentation. Breast milk is the first and best choice for all infants, including those with food allergy. It supports immune development, gut health, and overall growth. Supporting breastfeeding mothers is an essential part of managing cow's milk allergy in infancy. A hypoallergenic formula is one that is tolerated by at least 90% of infants with proven cow's milk allergy. Only extensively hydrolyzed formulas and amino acid formulas meet this definition. These formulas reduce allergenicity by breaking down the proteins into smaller peptides, as in extensively hydrolyzed formulas, or are based on individual amino acids in amino acid formulas. This slide shows a visual example of different protein structures. Intact long protein chains are found in cow's milk. Extensively hydrolyzed proteins, intact cow's milk protein is broken down into the smaller peptides, and this is why we call it extensively hydrolyzed. Short chain peptides are less likely to cause an allergic reaction. The amino acid formulas consist of just the individual amino acids and the building blocks of protein. As noted in the previous slide, only extensively hydrolyzed and amino acid formulas meet the definition of being a hypoallergenic formula. Askia provides an evidence-based, stepwise, symptom-guided approach to managing cow's milk protein allergy in formula-fed infants. The age of the infant and the clinical characteristics of the cow's milk allergy should determine the type of formula most appropriate as an initial option. These recommendations help clinicians select the most appropriate formula while minimizing unnecessary restrictions and risk. Cow's milk allergy is often resolved in early childhood. It is important that children with cow's milk allergy are regularly reviewed and tailored reintroduction is considered to avoid unnecessary dietary restriction. Formula choice must ensure nutritional adequacy with attention to growth and symptom resolution. Askia provides detailed tables of all suitable specialised formulas available in Australia and New Zealand, including indications and access pathways. Extensively hydrolysed formulas are recommended as first line for formula-fed infants under 6 months of age without anaphylaxis. Amino acid formulas are recommended for formula-fed infants with severe cow's milk allergy, anaphylaxis, eosinophilic esophagitis, or for those infants when the symptoms persist despite the adequate trial of the first-line options, such as the extensively hydrolysed formulas. Soy and rice-based formulas may be appropriate in selected older infants, provided they are tolerated. Ongoing review is essential. If symptoms do not improve, reassessment and an adjustment of the treatment approach, e.g. to amino acid formulas, is recommended, ideally in partnership with an allergy specialist and a paediatric dietitian. Specific clinical features indicate the need for specialist referral and consideration of an amino acid formula. These include failure on extensively hydrolysed formula, faltering growth, severe gastrointestinal allergies, and anaphylaxis. When these red flags are present, prompt referral to a GP, paediatrician, or allergy specialist is essential. Standard cow's milk-based formulas, partially hydrolysed formulas, and goat or other mammalian milk products are not suitable for managing cow's milk allergy. Standard cow's milk-based formulas are not suitable for managing cow's milk allergy, as these formulas are based on cow's milk. Partially hydrolysed formulas are not suitable, as the cow's milk protein has only partially been broken down, and so they can still cause an allergy. Goat's milk and sheep milk-based formulas are not suitable for managing cow's milk allergy, as the proteins in these milks are very similar to the proteins in cow's milk. There is increasing evidence linking gut microbiota composition with immune development and allergic disease. Early life nutrition plays a critical role in shaping the gut microbiome and immune responses. Infants with cow's milk allergy often have altered gut microbiome with lowered levels of beneficial bifidobacteria and higher levels of harmful bacteria such as Clostridium in their gut compared to healthy breastfed infants. This imbalance, gut dysbiosis, may influence immune development and susceptibility to infection. A healthy, balanced gut microbiome acts as a barrier against the infiltration and colonisation of pathogens, thereby protecting infants against infections. Synbiotics are a combination of prebiotics and probiotics. Prebiotics are a non-digestible food ingredient that stimulates the growth or activity of beneficial gut bacteria. A probiotic, on the other hand, is a type of beneficial bacteria that can help to rebalance gut microbiome when consumed in the right amount. The objective of combining pre and probiotics is to achieve stronger positive effects than with either component alone, so that they're working synergistically. Some studies have shown that synbiotics could help support gut microbiome balance and immune regulation. Lactose remains the preferred carbohydrate for infants, including those with cow's milk allergy. Routine avoidance of lactose in cow's milk allergy is unnecessary unless the infant has significant gastro symptoms, such as severe diarrhea. Lactose-containing hypoallergenic formulas such as the EHF offer potential benefits in the treatment of formula-fed infants with cow's milk allergy as shown. For formula-fed infants with cow's milk allergy, specialised formulas that support the gut microbiome and immune function should be considered as part of a broader management plan. This slide shows specialised formulas available to support formula-fed infants with cow's milk allergy as noted by Askia. Rice-based hydrolyzed formulas are an alternative option for some infants, provided rice allergy is not present and nutritional adequacy is ensured. Pharmacists can provide valuable support and reassurance to parents and caregivers during the introduction of a hypoallergenic formula. Clear guidance and reassurance about what to expect when starting specialised formulas can strongly support consistent use and outcomes. This case study, based on a call to the Nutrition Care line, highlights some of the confusion about cow's milk allergy, lactose intolerance, and the importance of careful assessment of symptoms. Symptoms such as constipation and discomfort require thorough clinical review to avoid unnecessary formula changes or misdiagnosis. In this scenario, lactose intolerance is unlikely and further assessment is required before making dietary changes. Supporting the mother, validating her concerns, and ensuring appropriate referral are key steps in care. Cow's milk allergy is common in infancy and often presents with multiple symptoms. Clear differentiation from lactose intolerance, appropriate dietary management, and breastfeeding support are essential. For formula-fed infants, formula choice should be guided by age and clinical presentation. Askia provide evidence-based management guidelines. Infants with cow's milk allergy often have an imbalanced gut microbiome, which can impact the immune development. For formula-fed infants, specialised formulas with factors to support the gut microbiome and the immune system should be considered. Referral to a GP, paediatrician, or specialist allergist is essential for ongoing management and monitoring for resolution. Reliable, evidence-based resources such as Askia and the National Allergy Council provide valuable support for both healthcare professionals and families. Thank you for completing this module. We hope you now feel more confident recognising the symptoms of cow's milk allergy, distinguishing IgE from non-IgE presentations, understanding how cow's milk allergy differs from lactose intolerance, knowing recommended feeding options in Australia, and identifying when referral to a GP or paediatrician is appropriate. Finally, remember that ongoing support is essential. Nutrition Care line team, including midwives, dietitians, and nutritionists, is available to assist both healthcare professionals and parents. Feel free to encourage families to reach out for guidance, reassurance, and practical feeding advice. Thank you for your time today.